This is a Defocus Media production. What's up, everyone? It's your favorite optometrist, Dr. Darryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. What's up, everyone? It's your favorite optometrist, Dr. Darryl Glover. Today, I'm super excited. I am thrilled because we are kicking off a new series, Eye Care Experts, and we're doing this with Grand Rounds. We're taking that type of approach. So Grand Rounds with Eye Care Experts, and we have nothing but experts on the panels, from optometrists to student optometrists, and we're really going to have a great conversation. We're going to break down a clinical case that's going to help elevate how you practice in your exam lane. So friends and family, I am super excited, and I'm super excited to welcome and introduce you to this all-star lineup. To begin with, we have really, Dr. Rueff, you've been a part of this team. You're like part of the Defocus Media family. I think you've been on the podcast more than anyone else. So, it's great to have you on the show again. How are you doing this evening?
I'm great. Thanks for having me back, Darryl. I like to think I'm part of the family too. So
you are part of the family.
I think so too.
We have so many things that are in common, from kids to the love of optometry to travel. I mean, I love stalking you on Instagram and seeing all the amazing places and things that you're doing. Right.
Likewise. Yeah.
But we also have another great star with us, a rising star, Arah Cho. How are you doing today, Arah?
Good. Excited to be a small part of the family, hopefully.
Well, thanks so much for partnering with us on this podcast and this Grand Rounds. And then we have the life of the party, Dr. Jeffrey Fardink. How are you doing today, sir?
I am doing great. It's a pleasure to be here. Very happy to be here with this talented crew.
Awesome. Well, before we get started, I'd love for each one of you to just break down, how you got into optometry, where you practice. Just give us a little bit about your background, if you don't mind. And let's take it from the top with you, Dr. Rueff.
Yeah, I'm Erin Rueff. I am Chief of the Cornea and Contact Lens Services at SECO at Southern California College of Optometry at Marshall B. Ketchum University in Orange County. I teach in the contact lens curriculum there, and obviously see patients and do all things contact lens related. My background, I went to Ohio State and did a cornea contact lens residency and also got a PhD in vision science there. So I kind of do a little bit of everything and really enjoy talking all things contact lenses, which is what we'll do tonight.
Awesome. Arah?
Yeah, so my name is Arah. I am a fourth year optometry right at the school that Dr. Rueff teaches at SCCO. I was born in the States, but I grew up abroad in South America for quite a few years. And then I went to UCLA for undergrad. And then I decided to come to SCCO, and I've been there ever since. I'm had the fortune, I guess, of doing a dual program right now. So I'm doing the OD program and then also doing a master's in vision science.
Oh, wow. That's fantastic. How's that process and that program been so far?
It's good. It's been challenging at times, I think, just because when you're trying to balance both. But I think I'm at a really good place right now. I have a great advisee, just kind of helping me along. And so I'm at the process where I'm writing up my thesis to defend it.
Fantastic. Well, the one thing eye care would teach you is how to be efficient with time. So I'm pretty sure that program is going to prepare you for the real world, and you'll be able to get into that exam lane and help patients day in and day out. Jeffrey, tell us about yourself, man. I've heard nothing but great things. So you got to share the world who you are and where you practice and what you do, my friend.
I'm glad to hear I've been bribing the right people in that case. I've had a lifelong love for contact lenses, and like all contact lens specialists, I'm sitting here with my glasses on, of course. But I was grateful enough to get into the Ohio State University College of Optometry, where I wanted to go because they had the best faculty, the best professors, including, of course, Dr. Rueff. That's why I wanted to go there. And since getting out, I've worked in many modalities, worked in MD practices, really medicine-focused practices, private practices. And I'm now, I've got 3 retail locations. And thanks to my great Ohio State training, I've got the interesting designation of being the busiest scleral lens practice in the area, despite being in a retail setting. So you can do anything you want there. I guess I'm proving that. So,
and I love that. And I love all the different backgrounds here, right? You have someone in academia, you have a student, you have someone that is practicing all different modes of optometry. we all have to be together in order to really make an imprint or make an impact in the world of eye care. We can all learn from each other, and this is proof here. And tonight, we're really going to dive into a great case. Just to give everyone an overview of what this show is going to look like, what this podcast stream is going to look like, Dr. Rueff and Arah is going to actually have a good conversation, a dialogue about a case. We're going to have a PowerPoint presentation, and they're going to go through the case. And Arah is going to be in a hot seat. We're going to ask her all the tough questions. She's going to walk us through and make sure that we have all the answers when we're done. And after they are done with the case, Dr. Fardink is going to come back on, and then we're going to have an expert panel, and all three are going to have a good conversation and dialogue about best practices with the clinical case that we have at hand. So I don't know about y'all, but I'm ready. Myself and Dr. Fardink, we're going to drop off, and we're going to let these two amazing stars take over. So are you ladies ready to jump into it?
I'm ready. If you could put those slides up for me, Darryl, we'll get going.
All right, let's make it happen.
All right, so Arah, this will be less of a grilling and more of a conversation. We're not on the clinic floor today. So okay, well, let's get started here. I'm trying to advance the slide. Let's see. There we go. So we want to thank our sponsors tonight, Johnson & Johnson Vision, for sponsoring this conversation and helping us to kind of get together and talk about some things clinically that especially students see that I found in my practice when I teach and work with students on the floor are confusing topics, or sometimes just topics that, you feel like you need more context to or more elaboration on. So hopefully we can get into that tonight and throughout this series, because this is just the beginning of, again, a series of grand round style production. So let's get going. So I'm going to present a case, and I guess, Arah, I'm going to present sort of minimal information here. So feel free to chime in and ask me if you want any additional information or need any additional information before moving on, or to answer any of the questions I might ask. So here's the case we're going to talk about tonight. It's a 22-year-old Caucasian female presenting to your clinic with a red, painful left eye. She says that the pain started this morning right when she woke up. The eye was watery, red, a little blurry. There wasn't really, thick discharge per se, but she'd rate her pain about a 5 out of 10. When you asked her about some of her contact lens wearing history, because I guess it doesn't say it explicitly here, but this is a contact lens wearer, she says that she wears a monthly replacement modality, but she does admit to sleeping in the lenses about 3 to 4 times a week. So that's sort of the history. Anything else you want to know, Arah, before we move on to some of the clinical findings?
I guess just, maybe what her visual acuities were like, or maybe some pictures of how she is presenting as well too. I think that's
that's a good question. She stated her vision was a little blurry in that eye. The right eye she came in wearing her glasses, actually, because her eyes were so irritated. Her right eye was an easy 20/20. That left eye was sort of a rough 20/30 plus, 20/25 minus. And when we looked at the anterior segment, this is what we saw. So looking at this picture here, we can kind of see, some sort of lesion down here in the inferior temporal kind of quadrant. Mm-hmm. When I put fluorescein in, this is what I saw. So I don't know, describe kind of what you see here. Sometimes before I name something I see on the cornea, especially the cornea, because things can be feel so elusive or tough to just discern and discriminate on the cornea. Sometimes just describe mm-hmm. what I'm seeing. So how would you describe the lesion we're seeing in these two, sort of in the white light photo and the fluorescein photo?
Yeah, so I definitely see some sort of lesion going on, like you mentioned, inferior temporally. Doesn't look to be too large in size, probably maybe 0.5 millimeter. Mm-hmm. Thankfully, it looks like it's not anywhere near the visual axis. And then definitely with the staining, you can see that there is quite a bit of staining kind of overall the lesion that seems to kind of correspond to the lesion we saw in the direct light.
Yep. Yeah. So that was a really great description. I liked how you mentioned that it wasn't in the visual axis, that it, the relative size of it. Obviously, we don't have a reticule or ruler here, but I agree. It probably looks about 0.5 millimeter. If I would ask you to call that something, what would you call it?
I think, yeah, just based on the white light alone, it'd be kind of hard to tell whether it was an ulcer or not, but definitely with the staining pattern going on, I would call it most likely an ulcer peripherally in the left eye.
Yeah, I agree with you. And I like how you said, like, without the white light, it's hard to tell. And this is a topic I feel like comes up a lot when we have red eyes related to contact lens wear in the clinic. With white light, we can see there's sort of a white lesion there, a white fluffy lesion there. And the first thing I think we want to say is that's an infiltrate, right? But with stain, we can see that it stains most of the way. And so oftentimes the question, we're asking ourselves clinically is this, an infiltrate, or is this a full-on ulcer? So let's go over how we can kind of tell the difference between those things. And it's sometimes not perfectly clear, but really an infiltrate is sort of the beginning stages of an ulcer. I like to think of an infiltrate as almost like if you let it go unchecked, it can turn into an ulcer. So an infiltrate is going to be an accumulation of white blood cells. We'd usually describe it as just subepithelially. Infiltrates can be sterile or infectious. They may have associated staining. They may have associated edema. There might be one big, large infiltrate, and there might be a situation where you have lots of small, sort of white, fluffy, almost hard to view infiltrates. So again, an infiltrate is sort of just the beginning of an inflammatory process in the cornea. An ulcer is an infiltrate with an overlying epithelial defect. So kind of like our picture showed, once we put stain in this patient, we saw that basically the entire area of that infiltrate stained with sodium fluorescein, indicating that, there's been enough inflammation there to cause the epithelium to sort of ulcerate away. Ulcers can also be sterile or infectious. And when we look at ulcers, it's important to measure the size of the epithelial defect, the staining size, in relation to the size of the infiltrate. So what would be the ratio you would say that lesion had sort of like staining to infiltrate size? What would you call that?
I think grossly, when I was just looking at the pictures, I would say more likely that it's a 1-to-1 ratio between the staining and the infiltrate size itself.
Yeah, I would agree with that. It's basically 100% stain, right? So as we treat and manage this, we're kind of looking to see how that epithelial defect changes over time. It's important to note that oftentimes you will have staining involved with sterile infiltrates or just infiltrates in general. You might have SPK. And so it's not always, just like so many things in diagnosing ocular disease, it's not always perfectly cut and dry, like staining or no staining. But when we're differentiating an ulcer, we're really looking for that sort of somewhat well-defined epithelial defect right over top of the infiltrate there. So yeah, I would agree. This is a corneal ulcer. How would you call it anything else based on sort of how you've learned about corneal infiltrates in the past? Would you just say they've got a corneal ulcer? Would you describe it with any more detail?
Yeah, so I think kind of going back to what I mentioned before, I think just mentioning where exactly on the cornea is pretty important in the sense that, it could eventually lead to scarring is what I've learned. And so you kind of want to keep that in mind in your management process as well, too, to see, is it something that you're very, very concerned about in maintaining and making sure that doesn't scar? Or is that something that, just because for this case, at least, it's more peripheral, so it doesn't concern you as much of it not being in the visual axis. And so, yeah. And then I kind of had a follow-up question as well, too, Dr. Rueff. How, I guess, important do you find it to be that you get exact measurements of how big the ulcer is? Do you feel like that's imperative in your management for ulcers and seeing if that epithelial defect kind of resolves with time? Especially just if you're in a busier clinic where maybe you're not the ones that following up with that same patient. And so you kind of have to leave behind a chart that the next patient has to see. Or do you feel like kind of eyeballing it relatively pupil size to the pupil size is the best way to go? I guess, what would you say?
I mean, I'm a big proponent of the more you can, or the more precisely you can document, the better. And I think that's a good point, especially if you're in a clinic where maybe someone else will see this person at the next visit. It's great to get in there and measure the size of the defect, the size of the infiltrate, maybe, the distance from the limbus, or maybe the distance from the visual axis, depending on, maybe which you're closer to. So yeah, the more you document, the better. So yeah, those are all good points. Talking about, how close it is to the visual axis might also influence how we manage it. So we can talk about that a little bit later. When we talk about infiltrative events in the cornea, all the students out there who are watching this might recognize, this graphic, or might recognize some of these diagnostic terms that we use when diagnosing corneal infiltrative events on the cornea. And again, I think this can be a really confusing topic to a lot of students and doctors who are diagnosing and managing corneal infiltrative events. We, if we look at this sort of flow chart of corneal infiltrative events, you can see some terms that I'm sure you're all familiar with, terms like infiltrative keratitis, contact lens induced acute red eye or CLAIR, CLPU, or contact lens induced peripheral ulcer. And oftentimes, I feel like we want to put every patient in a box of, this is the exact diagnosis for this patient, this is exactly what they have. But I think it's important to acknowledge that most corneal infiltrative events kind of happen on a spectrum here. So again, if we kind of think of inflammation in the cornea, especially as it relates to contact lens wear, it usually starts out as sort of sterile inflammation, sterile asymptomatic inflammation. And as it's left to go unchecked, maybe as compliance wanes, we see those infiltrates potentially form into sort of more of an ulcerative event. And then again, if it left to go completely unchecked, can kind of progress to, our worst case scenario, which is vision threatening microbial keratitis. So for this patient, I think this is a pretty classic case of a contact lens peripheral ulcer. So kind of, at this diagram, what we're seeing here. But what I want to mention here is that a lot of infiltrative events can sort of overlap. So, we often talk about CLAIR. CLAIR stands for, again, contact lens acute red eye. And by definition, that just means a patient slept in their lenses and woke up with a red, painful eye. But that patient could have just infiltrates. They could have just an ulcer. They could have a bunch of infiltrates and an ulcer. And so you can kind of see here, I really like this diagram here that shows that corneal infiltrative events, in the last slide, we said they were a spectrum. And this is kind of showing that they're actually sort of this big Venn diagram kind of. So I say this to not make the diagnosis of corneal infiltrative events more confusing, but to sort of put you at ease as you're encountering corneal infiltrative events clinically, in that it can oftentimes be one, or it can be both, or maybe multiple forms, and that's okay. What you really want to think about is, your patient's risk of infection and what the best management is. So this was actually the treatment we initiated for this particular patient. And we'll talk about why sort of as we move along here. But so basically what we did was obviously tell the patient to discontinue contact lens wear. And we put this patient on an antibiotic steroid combination drop 4 times a day in that left eye for a week. We also suggested they begin preservative-free artificial tears a few times a day and return to the clinic in 1 to 2 days. We made sure we educated them really well that their symptoms should only improve with medication. Their symptoms should not worsen between now and when that follow-up is scheduled. And if they do, that's a sign that maybe something else is going on. They should return right away. So when you see that treatment plan, what do you think of that, Arah?
Yeah, so I actually have a couple questions kind of off the bat. I feel like management is probably one of the hardest things to come up with as a student, and determining, because, there, like you said, there's such a wide, varied kind of spectrum of presentations and how much the severity is, and you kind of have to judge that and make the best decision for your patient. So I feel like for just ulcers in general, I've heard quite a few things and range of how you actually manage an ulcer. Mm-hmm. I've heard things where you shouldn't actually start them on a steroid until the epithelium defect has completely healed. I've also heard that, maybe antibiotics, you want to start them on every hour just because you don't want that ulcer to progress. And so for this case specifically, how did you find that giving them the antibiotic steroid was all right. And then dosing that at 4 times a day was kind of the best management.
Yeah, that's a really great question. Steroids can feel kind of scary, especially when like infection could be a risk. And so we need to sort of weigh the risk of infection in this patient and try to kind of get a sense of, the risk versus reward of using a steroid in this case. So, the benefit of using a steroid is it's going to make the patient feel better quickly, right? Because it's going to eliminate inflammation. It's also going to reduce scarring and just generally help the whole situation heal faster. The risk of a steroid is obviously it can decrease our immune system's ability to respond to infection. So if there is active infection there, that could make the patient susceptible to that. Obviously, choosing a combination drop that includes an antibiotic, specifically an antibiotic that has good gram-negative coverage for a contact lens wearer who might be at a higher risk for Pseudomonas infection, helps cover us there. If this was a patient that had an ulcer closer to the visual axis, was experiencing more pain, had more signs, which I'm going to talk to you about some more signs in a minute here, of high risk for infection, I probably would have just started with an antibiotic, like you were saying, kind of every hour, maybe every 2 hours. But because this patient had, relatively mild, moderate pain, not a lot of associated symptoms associated with infection, using a steroid antibiotic combination is actually really appropriate here. How this patient presented indicated that she had a low risk of this being, an acute infectious event. And because we had an antibiotic kind of paired in with our steroid there, that kind of covered us, at least in the initial stages for her. When I'm trying to think about, is a steroid okay? I sort of have this table in my head. This is sort of like what I'm thinking about in my head. And this is sort of signs and symptoms that my patient is experiencing that would indicate that the lesion is more or less likely to be sterile or infectious. So I won't read through all of these here, but those who are watching can kind of look at the list. This patient had a peripheral lesion. It was less than 1 millimeter in size. Mild pain, no anterior chamber reaction. As we go down this list, she's really erring on the side of sterile, which indicates to me that I can pretty safely utilize a steroid to make her feel better quicker and also to have this lesion heal faster and minimize scarring. Even though this isn't in her visual axis, we still want to minimize scarring as much as possible. The other good thing about using a steroid, or the other thing you should make sure you do when using a steroid, as I mentioned in her in her management slide, is that we want to make sure we educate the patient that, their signs and their symptoms of discomfort should only get better. They may not get better the minute they start taking the medication, but they shouldn't get worse. And they should, at least start getting better over the treatment period. If the patient understands that, then they know that if, they begin using the steroid and something funny starts to happen, they feel comfortable contacting you and coming back in for follow-up. I also have noted here, using just an antibiotic in this case would not be wrong. If that is what you feel comfortable with and you want to take the more conservative route, that's okay. But the resolution of the condition may just not go as quickly. And so that's why in this case, I think using a combination drop is appropriate. Let's talk about her follow-up. So she came back 2 days later with improved symptoms, just really mild irritation. She had reported good compliance with the medication. And when we looked at the slit lamp, we saw that the infiltrate had reduced in size, and really there was no significant epithelial staining, maybe just some SPK there. So we were really happy with that improvement. Things were looking really good. And so we told her to continue the drop for the full week, right? We want to continue that antibiotic steroid, even though things were looking better, there was still some inflammation it could tackle there, sort of the full 7 days, stay out of the contact lenses. And at this time, we started talking to her about, when we do resume contact lens wear, we might want to start thinking about a new modality, better compliance, maybe a daily disposable. Started to kind of plant the seed early that, you're going to need to change the way you utilize contact lenses in the future. What do you think about that follow-up? Is that what you expected?
Yeah, it was. And I feel like I always like to kind of imagine scenarios that might not be as straightforward. So I know based on the first visit that you recommended that she come back 2 days later, which she did. Just to play a kind of like devil's advocate here, let's say you were in a clinic that it was a Friday that you saw her for initial presentation, and that clinic is closed till Monday. Technically, that is about 3 days away. How, I guess, would you respond to that situation? Do you feel like it's urgent enough that you would come back to the practice either on a Saturday or on a Sunday and see her? Or do you feel like, in that case, just because it is more peripheral and not as large in size, you'd be okay waiting till Monday to see her?
Yeah, great question, because that is real life, right? This is the stuff that walks in at 4:45 on a Friday, right? When you think you're going to go away for the weekend. And you kind of ask yourself that question, like in a perfect world, I'd see you back in 24 or 48 hours, but that's not always possible. So, there's a lot of different ways you could approach that, and everybody would approach it differently. Some people might say, if you were, really thinking there could be a chance that this was an infectious lesion, you might come in over the weekend when your practice was closed and maybe see that patient after hours. Some people might say, this is a great time, this is when patient education is so important, right? So making sure the patient understands how their symptoms should or should not progress over that time period, and making sure the patient has someone to contact or communicate with if things start to feel weird or off. So I think most of us have an on-call pager or on-call doctor over most weekends or holidays. So that would be great. You could give your patient your on-call number. If you felt strongly about it, or depending on your particular situation, you might just give them your cell phone number over the weekend and say, hey, shoot me a text if you feel like things aren't getting better. So whatever you feel comfortable with. But in most cases, and specifically in this case, like personally, I feel like as long as I educated the patient about what her symptoms should do over the weekend, which, as I mentioned, should only get better, not worsen, that she should be okay to wait until, maybe first thing Monday morning to come in. But with these types of things, I just found as long as the patient feels like they can openly communicate with you, that's good. Good question.
That's really good to hear, because it's kind of like,
it's real life.
That's real life. Like you just end up in clinic, and like you said, a lot of this walks in last appointment of the day for the week. And so, I just wanted to see how you would respond.
Yes. Yeah. I actually had a patient like this once. It was the Friday before 4th of July weekend. She had a big meaty ulcer. And of course she was like off to the lake to go water skiing all weekend. So yeah, that was definitely one of those where I was like, here's my cell phone number. Don't go in the lake.
That would be a good idea too.
All right, so let's talk about her 10-day follow-up. So, she did the whole course of medication. I actually had her do the medication for a week, stop the medication. So by the time she saw me back, she had kind of been off all meds for a few days, comes in, no symptoms, no complaints. She is eager to get back into her contact lenses. We take a look at the slit lamp, look at her cornea, and things are looking good. And we actually just see a corneal scar when I look at her slit lamp assessment. So here's an example of a corneal scar. How do I know if it's a scar or if that infiltrate is still like a little bit active?
So I think for me, the way I understood it, that scars, it just is a little bit probably more defined in its borders compared to an infiltrate. I think a lot of, I guess, my knowledge of the patient as well too is going to help a lot in determining whether that's a scar, just because I've seen her 10 days ago when it was active. And at this point, we've been putting that antibiotic steroid combination for her. But yeah, I think the difficulty for me lies in the fact that I think I know how to different, or at least book-wise, know the difference between the scar and an infiltrate. But as a student, I haven't seen too many of infiltrates itself. I guess that is where the difficulty lies in for me in differentiating between the two. And so do you have like any specific tips into how you approach differentiating the infiltrate versus the scar? If you
it's tough. It's tough. And in a case like this, like when we know the patient's sort of their recent history, I kind of know that she's been off the medication for a few days. She's asymptomatic. Some things I'm looking for is some of these things here. So like you said, a corneal scar is going to be more defined. It typically doesn't have associated staining, no associated sort of like surrounding edema. Hang on, there's a question here. Yes, she should be advised, in this case, she should be advised to discontinue contact lens wear until further notice. And that's what we'll talk about as we move forward here, because she had been sleeping in them, abusing them. Maybe she didn't know she was abusing them. Maybe we need to talk to her more about that. But yeah, we definitely don't want her to be wearing contact lenses right now. So again, back to the scar. So in this patient, we kind of know what to look for. We're looking for those defined borders, no staining, no edema. Oftentimes you're going to see corneal scars just sort of out in the wild, right? Like a patient comes in for a routine exam, you kind of look at their cornea and you're like, oh, they've got a bunch of lesions on here, but they're not complaining of any symptoms. That's a great time to ask, if the patient has had any history of an eye infection. Usually, obviously scars are going to be asymptomatic. Infiltrates are going to typically come with some symptoms, some associated edema, some associated staining, redness, those kinds of things. So scars can sometimes be hard to tell. Is that an infiltrate or is that an ulcer? Or sorry, is that a scar or is that an active infiltrate? But the more you see, the more you'll be able to differentiate that. Okay, so moving on here. So we at 10-day follow-up, we say that ulcer is resolved. She's safe to resume contact lens wear, but we want to start talking to her about how best to safely resume contact lens wear. So in this case, a daily disposable is hands down the best option for our patients. We know that daily disposables are going to decrease her risk of just corneal infiltrative events in general. And they also decrease if a patient would have the lucky circumstance of developing microbial keratitis, daily disposable wearers have less severe microbial keratitis, so less vision threatening. So let's talk about in the discussion here, we'll bring Dr. Fardink in and talk about how we can talk to our patients about daily disposables and how to, convince them that that's the best modality for them and how to choose a daily disposable for a patient. So I'll kind of start the discussion here and then Jeff, Arah chime in. I know when I talk to my patients about daily disposable contact lens wear, I want to avoid, being judgmental or condescending about maybe how they were non-compliant in the past, because a lot of times they just weren't compliant because they weren't educated well. So I want to make sure I educate them on, why they want to be replacing their lenses, not sleeping in their lenses, but also choosing a modality where they can get a clean, fresh lens every day, how that helps them avoid things like pain and permanent vision loss, and sort of asking them questions about why they're non-compliant, so that we can better address that non-compliance. So specifically, asking them like, hey, are you sleeping in them because you're not great at applying and removing the lenses? What's the reason why you're sleeping in them at night? So I don't know how Jeff, you talk to your patients about compliance.
Well, I think that you are a better human than me by trying to avoid being judgmental, because I struggle with that a lot myself. I will skip straight to judgment. So, why is this patient perhaps misusing the contact lenses or sleeping in them or wearing them longer than the 2 weeks or month that they're indicated? Absolutely, you want to make sure that you educate them. And sometimes they just don't know any better. Yeah. But usually they just have these bad habits and it's tough to break them. A lot of times you'll get a patient like this in a monthly lens. You say, okay, no contacts for a week. They don't even have glasses because they just don't have them. So making sure that your contact lens patients have a pair of glasses. I say ones that you can feel comfortable driving with. Sometimes they're not the most recent or accurate pair, but as long as they work, they're much less likely to have an event like this because they don't have to abuse their contacts to be able to function. So you can even avoid having patients like this by making sure they have their glasses, before an event like this happens. But a big thing too is that sometimes patients are non-compliant. They struggle with getting them out at night. They're tired. They don't want to wash their hands and put them in the case and make sure their solution's clean. So that same patient who maybe doesn't even have glasses, when you get them into a daily lens, they might not even have a contact lens case to put the dailies in and abuse them with, So I'll find patients like this who struggle with compliance will almost never abuse their daily lenses or sleep in them or try to reuse them in a case for 2 or 3 days, because patients just, for whatever reason, just don't seem to do that with dailies for the most part. I have patients who do those things, but for the most part, you get a non-compliant patient into a daily and suddenly they're compliant because the compliance is just so much easier to do. So I will be judgmental. I will think this patient's going to do it again in a monthly. So I really push them into a daily. And it is a struggle sometimes to get your patients to switch to dailies, but for the most part, not a patient like this. They've seen what happens. They don't want it to happen again for the most part, and they're easier to convince to go into a daily.
Yeah, once they've had like that eye pain, it's like, oh, ouch. Yeah, I agree. I guess I try to avoid being judgmental and condescending. Maybe I am in my mind, right? Like I've just found if I come at my patient less of like wagging my finger at them, they're more likely to listen to my pitch for, hey, here's what I think you should do. So I try to do more of like, okay, I hear what you're saying, but let me offer you a solution to that.
Yeah. And an important thing there too is I always make sure to come across that I'm not scolding my patients, I'm educating them, because
there you go.
When I go home that night, I'm not going to think, man, that patient was non-compliant. I sure am disappointed in them. I don't care. I want their eye to be healthy, but I educate them and I trust them to make the decision that's right for them, even if it's not the one that I would make.
Yeah. I totally agree with that. I think also what can also be hard when you take like a monthly wearer who maybe is wearing their lenses for 3 months, they're not used to purchasing lenses very frequently, right?
Sure.
And so a big, hurdle, at least initially can feel like a big hurdle, is, talking about the cost differences between like a monthly or 2-week lens and a daily disposable lens. I found, at least in the last few years, I don't know if you found this, Jeff, I found that has been a lot easier because we have so many great options sort of on a range of budget available to us. I'm thinking, J&J is sponsoring us tonight. I'm thinking of their portfolio. So they've got, premium lenses like the new ACUVUE OASYS Max and the ACUVUE OASYS One Day, but also more sort of budget friendly, sort of entry level from a price point standpoint, like the ACUVUE One Day Moist lens. And most manufacturers have sort of a range like that. So we really have options for patients. Again, it can be kind of surprising to go from, paying for your lenses once every other year, if you're in that monthly modality, to the daily. So I don't know if you have any thoughts on that.
Well, I agree with what you said. The price has come way, way down in the last 5, 10, 20 years. So that's much less of a barrier to entry for patients. And, it's about making the pragmatic right decision for the patient. I've got some clinician friends who will feel like the DK of the moist in the 20s is, not as high as they want it to be. It's very rare I've had a patient who's had an issue with a DK like that. That DK is high enough for 95 to 100% of the patients that you'll see on a daily basis. And if you are concerned about DK, that's great. But I'm more concerned about this patient having more infiltrative events. So I would much rather take that low risk than risk this happening again. So it's about weighing the pros and cons, and the barrier to entry being less with the price is a big thing.
Totally. And if your patient is compliant with that lens, then that DK isn't as much of it shouldn't be as much of
they're not sleeping in it, so it's great.
Yeah. Other things you can kind of talk to your patients about as far as like cost, most manufacturers are offering really great rebates for daily disposables these days. Also, if you consider the cost, if you're buying a bottle of solution every month, a $10, $15 bottle of solution every month, and you extrapolate that over a year, that actually usually makes your monthly lenses as or more expensive than a daily disposable. You sometimes just have to sort of price that out and kind of talk that out with a patient. And that's kind of like, oh, okay. The upfront cost is more, but over the year it's not. So, any thoughts on that, Arah? I don't know if you've ever had to convince a patient to switch to daily disposables.
So it was actually a friend of mine, which I feel like can be a good and a bad thing if you know the patient that you're trying to convince. I actually switched her into the One Day Moist. I think for her, it's, similar concept where price was kind of the biggest factor for her, just because she was a grad student as well too. But she upfront told me she's a contact lens abuser, in the sense that she used to wear biweekly lenses. And so kind of told her like, hey, just think about the convenience. She's a dental student, so she's kind of has to wear contact lenses and up at all hours of the day studying as well too. And so I kind of equate it as like, think about the convenience as well too that it'll bring you. First, it's just overall better for your eyes, and then second of all, it's just really convenient. You could just take them off at the end of the day and throw it away, and you don't have to deal with solutions or like ordering them or different things like that. And so I managed to wrangle her in, and she did end up actually buying an annual supply on the spot, which I was very proud of.
Wow, good work.
Yeah, so that was kind of my first taste. But I guess my question is, do you guys have like a specific case, maybe similar to this one, where it sticks out to you and how you were able to educate that patient to perhaps take better care of their lenses or switch into a daily modality?
Sure. So Dr. Rueff made a great point too about bringing up the cost of contact lens solution. I'll have patients like this who are hesitant about trying a daily, and they think, well, I'll just do a better job taking care of my monthlies. I'm like, well, that's great. So if you're buying that, so you have enough lenses to make it through the year, and you're buying enough solution so that you're spending $100 to $150 a year on solution, this is what the price to you is going to be. Whereas for the daily, this is what the price is going to be. And like she said, oftentimes the daily is at parity, if not cheaper. And a lot of times these patients who are sometimes making poor choices and abusing their lenses, I feel like it's because to them convenience is such an important factor. And man, there is nothing as convenient as a daily lens. So if you can just get them to take the plunge and take those trials home, I'll even say, I'll prescribe your monthly lens too. You have that security blanket. I'm not going to take it away from you. Just try the daily out. And so getting them to try it, they come back in, and most of the time they just love the convenience of it and the comfort. So it's make sure they have that security blanket when they need it of the monthly prescription if they want that.
Yeah, I agree. I've found, maybe not in a case like this where there's like an acute red eye, but maybe that non-compliant wear that you see every other year or so that you're like, something bad's going to happen. Just sending them home with some dailies. They'll call you back and want the prescription for that. After, once you throw away your lenses at night and don't have to do the case thing, you don't want to go back.
For sure.
So yeah, I think that's good. Awesome. Well, this has been a really good conversation. I hope all the students, I can see your guys' comments. You're all making really good comments.
Yeah. There was one comment I'd love to address briefly.
Yeah.
Someone made a comment of 3 strikes and you're out, no more contacts. I think that's sometimes you have to cut patients off, and I'm totally on board with that. Just keep in mind also that, you're not the only doc in town. I've had patients who I will tell things to like that. And then, I see them again a couple of years later, and they've gotten their contacts elsewhere. And I've realized if I can help that patient make a healthy choice that they're going to follow, like switching to the daily, it's tough, but it's oftentimes in their best interest too. So.
Yeah, I agree with that. Sometimes it's knowing that someone else may not have as good of their best interest in mind. You sort of have to make the best decision for them. Yeah. Somebody else said if they were young, they would encourage them to bring a parent or guardian with them to kind of hear the education, which is also a really, if you've got a 15-year-old, that would be really great to make sure mom or dad hears your gentle scolding, maybe.
Mm-hmm.
Awesome. Well, I think this has been a great conversation. Thanks to J&J for sponsoring us tonight. We will look forward to having more of these Grand Round style student-focused podcasts in the months to come. So, Darryl, I don't know if you're still out there.
Absolutely. I'm always in the mix here. I want to thank everyone for being a part of the show this evening. Look, you guys, this is fantastic. And this is what eye care is all about, right? Everyone on this call, everyone on this podcast is paying it forward. We are helping students. We are helping the future of optometry to make sure that they have all the tools and resources to be successful. I want to thank Johnson & Johnson Vision for being partners in regards to this live stream. But I also, most importantly, want to thank all 3 of you. Thank you for coming on and sharing your stories, but also sharing your knowledge and your insight. One thing I always tell everyone, and I want all the students to listen to this, is live through other people's experiences. You don't have to learn on your own and fail. Learn through everyone else, and it'll help make practice so much easier, and it'll help you excel earlier on in your career as well. And always keep in mind, you don't have all the answers. Reach out to a colleague, get a mentor, get some advice, text someone, phone a friend or something like that. It makes a world of difference. But thank you so much. We are doing a raffle. We have 3 winners today. The winners are Sophia Johnson, Peyton Taylor, and Noah Robinson. So you three are the winners. You get a $100 Amazon gift card. I'll have my assistant Sam email you and get that in motion. But thank you so much for tuning in with us this evening. This has been great. I see a lot of my mentees out there, a lot of great student doctors, the future of eye care out there. This is fantastic. Any last words from the expert panel here at all?
Thanks so much for having me. It's a pleasure to be here.
Likewise. Thanks for talking with us tonight.
Yeah, and thank you for just sharing all of your knowledge with me as well too. It was a great opportunity.
All right. Well, it's fantastic. Everyone stay healthy, positive, and blessed. And until next time, we'll check you out next month. We're going to have another one of these. We have about 5 more to go. But thanks for tuning in, and we'll see you next time. Peace. All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the Defocus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars. And make sure you follow us on all social media platforms. Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at Defocus Media on all platforms. And until next time, be sure to keep it 20.